Good afternoon, everyone. Thank you for joining the Police Mental Health Collaboration, a Different Way of Policing webinar. My name is Nicola Smith-Key. I'm a Senior Policy Analyst for the Law Enforcement Program at the Council of State Governments Justice Center. I have here with me Talia Peckerman, Policy Analyst for the Law Enforcement Program. Our two presenters for today will be Corporal Sam Myers from the San Marcos Police Department in Texas and Sergeant Yarbrough from Eldorado County Sheriff's Office in California. We will start the webinar with a brief overview of the mental health collaboration models, followed by examples from the field. Towards the end, we will have time for questions and answers. To ask a question, please type the question into the Q&A panel on the bottom right-hand corner of your screen. We will do our best to answer your questions. If your question does not get answered during the webinar, please follow up via email after the event has ended. At the end of the presentation, we will provide email addresses for everyone speaking today. We are recording the webinar, so both the webinar as well as the PowerPoint will be posted on our website shortly. So we'll begin with a very brief overview of what we're seeing happening in the field. The data shows that approximately 1 in 5 adults in the United States has a mental health disorder. Mental health calls for service, we're finding, tend to be some of the most complex and time-consuming for law enforcement officers, who in most cases provide the first line of crisis response. We're also coming across the fact that these calls for service are fairly common and constitute an estimated 7% of all police calls for service. So what is Police Mental Health Collaboration Program? It is a law enforcement-based program which involves collaborating with mental health or behavioral health entities. And the goal of a PMHC program is to divert individuals with mental illness from unnecessary jail booking and or hospitalization. We've also come across some benefits of a PMHC program. One of those are it increases the safety of the individuals. We also find that it reduces the financial and operational strain on both law enforcement as well as behavioral health resources. And we're also finding that it improves community relations. What we're going to look at now are some types of PMHC programs. We're going to look briefly at 5 such programs. These programs include crisis intervention teams, co-responder models, mobile crisis response teams, case management teams, and hybrid models. It's very important to realize that there's no one right type. So agencies need to first assess their community's needs and resources to determine which type of program is most appropriate for you. Note also that the 5 approaches are not necessarily mutually exclusive, and in fact, some agencies incorporate elements of different approaches into their program. We'll begin with the CIT, or Crisis Intervention Team, more commonly known as CIT. This model originated in the Memphis, Tennessee Police Agency and is therefore often called the Memphis Model. It's a pre-booking jail diversion program for people in crisis due to a mental illness. To be considered CIT trained, CIT International states that one must complete a 40-hour CIT training curriculum. Individuals should volunteer into the CIT program, and agencies should train at least 25% of their staff. The next model we'll look at briefly is the co-responder model. This approach draws upon the combined expertise of the responding officer and the mental health professional. For mental health-related calls for service, a specialized trained officer and a mental health crisis worker respond together to mental health calls for service. With this approach, the team is able to link people with mental illnesses to appropriate services or provide other effective and efficient responses. The third model that we'll look at briefly is the mobile crisis team. For this model, mental health professionals respond at the request of officers to the scene of calls or at requests directly from community members or family and friends. The mobile crisis team helps to stabilize encounters and assume responsibility for securing mental health services. The next model is the case management model, and I won't provide too much information here as one of our presenters will be talking more in detail about this model. What we wanted you to take away from this is that officers often, in collaboration with mental health professionals, carry a caseload of consumers by engaging individuals who have repeated interactions with law enforcement. Officers work with consumers to develop solutions specific to the individual's needs to reduce repeat interactions. The next slide, the hybrid approach. Law enforcement agencies intentionally select various response options to build a comprehensive and robust program. It begins with the expectation that every patrol officer must be able to respond effectively to mental health calls for service. And it also enhances their patrol force with officers or detectives whose primary responsibilities are to liaise with stakeholders and to coordinate criminal justice and mental health resources. I will now turn things over to Corporal Sam Myers from the San Marcos Police Department.
Good afternoon. Again, I'm Sam Myers. I work for the San Marcos, Texas Police Department. We are located about halfway in between Austin and San Antonio. We are about 50 to 55,000 population with 106 officers and 45 civilians. So what we do is we have a mental health unit that's comprised of myself and 2 other officers. We liaison between individuals in crisis, hospitals, local schools, and through our school resource officers, mental health support groups, community outreach, our local mental health authority, and other law enforcement agencies. We also work pretty close with the district attorney's office to assist with court orders and other things to get people the resources they need. We also periodically trying to do quarterly updates with patrol and other units in our department to update them on mental health issues and other resources that they may be able to use. We want to make sure that everybody's safe. We want to make sure that people are in an environment when they get screened that they're in a safe environment as well as a screener. We want to make sure that they get the resources. We do not treat or diagnose anybody, but we do try and get the resources there to assist them to get the diagnosis, treatment, and any other medication or whatever else it is that they need. We partner with the MCOT team, so that's our Mobile Crisis Outreach Team. So we are part of that with our local mental health authority. We try and do quite a bit of home visits. In fact, that's probably a majority of what we do is go, whether we are with our, the mental health specialists, the clinicians, or whether we go by ourselves. We try and divert those people who have had the prior mental health crisis to make sure that they're stable, to make sure that they're getting the medicine, to make sure they're following up with their doctor's appointments. And we work with our Shibe Center's MCOT team to assist local residents, university students, and everyone from our surrounding communities who rely on it. In fact, we have a very large, this year I believe their population is around 39,000 college students at Texas State University, which is right in the middle of our town. Typically, if we go without a mental health specialist, we're focusing on basic needs and minor problems, conduct basic assessments of individuals, and also we may go if the person is known to be a threat and we don't want the clinician to be there until we make sure it's safe. When we go with the mental health specialist, we typically go for the post-release, post-counseling, or any pre-detention issues. We typically try and keep it low-key and relaxed. Our job as a mental health officers is mainly situation awareness, security, and maybe doing a detention. And if the mental health specialist is with us, we usually let them take over the majority of the screening, interviews, and conversation. So emergency detentions are, some call them EDOs, we call them EDs. They're at the sole discretion of us. We will typically transport them to a local hospital, to the Shibe Center, or sometimes to a area mental health psychiatric emergency room. That's usually a pretty rare situation, but we do have one in Austin and one in San Antonio. Usually we will get them screened by a clinician, whether at our local emergency room or at the Shibe Center. There is, like I said, there is every so often we circumvent them and take them directly to a facility if we deem that that is the most appropriate for them. We put them on individuals who are self-harming, who have immediate issues of harming somebody else, or if they've decompensated to the degree that they've not able to take care of themselves due to the mental illness. We have basically 4 types of encounters we typically come across. The most common is the cooperative compliance. That's the people who are usually maybe only self-harming. They're not looking to hurt anybody else. They are actually, a lot of them are looking for help. They just don't know where to go. A lot of people never realize how many resources that we have available, and so we're trying to educate that as well to get that out there. We have the hostile, uncooperative, or uncompliant. Usually those are transported to a hospital or somewhere more secure like our police department before we do a screening. We may have to use restraints on the person. Again, we try and do least restrictive, so that may include just minor handcuffs or a waist restraint. We have those that require immediate medical attention. Maybe they've already done self-harm, they've cut themselves, they've taken medicine, or they have some other medical issue that needs to be taken care of, so they will go directly to a hospital. Or we will call it a mental health specialist to their location, to their home or to a location, but law enforcement will always be present on those. So transports, we try and do a majority of our transports within the 3-person unit that we have. We are trying to keep patrol from having to do any of the transports, whether they're our own emergency detentions or whether they're court-ordered orders of protective custody. Unfortunately, we only have one inpatient facility in Hays County, and it's age 55 and up. So our transports are typically 1 to 2, sometimes even a 4-hour turnaround before we come back, especially if we have to go to Kerrville, which is has our local Hill Country crisis stabilization unit at it. Restraints are, in my case, very rarely used. I believe I only use them 2 or 3 times in the last several months. So most people are pretty compliant. We do have body cameras that we use to record the entire transport. And if for some reason the mental health unit is unable to respond, we have a list of other officers who have volunteered to assist in transport. We try and maintain community involvement. There's a lot of community functions that we go to, NAMI meetings. We try and assist the Military Veteran Peer Network, which is part of our local Shibe network. We also work with the Veteran Service Office, which assists in all types of VA vet issues, not just mental health. And we've also been invited to participate in our local Hays County Veterans Court. One of the things we're really stressing right now is trying to upgrade our documentation, data collection, and statistics. It's still a work in progress, and there's still a lot of things going to get that on the track that we really want it. One of the things is we're requiring officers to start writing more reports whenever they have convinced someone to go to a hospital without actually detaining them, because we're missing several calls that have occurred that way. We're also doing a different way to search for our calls that we may have missed. So instead of searching by the activity code that the dispatchers type in, we are searching in the blotter or in the call log for certain keywords such as suicide, suicidal, mental, detention, Shibe, and several other words. There's about 12 to 15 words that we search, and we've been able to find quite a bit more reports that have kind of, quote, slipped through the cracks that we've been unable to find by the traditional methods. And beginning October 1st, we have a new tracking method whenever an officer does a report that involves a mental health aspect. there is a checkbox list of about 14 or 15 checkboxes that they have to complete. It doesn't take very long for the officer, but that gives us information such as what did we do with them, such as arrest, taken to the hospital, inpatient, was there force used, was anybody injured, was drugs or alcohol a factor, and questions like that. This is that box that we have added into our record reporting system. So basically the very first top left box, it says mental health related. If it's not mental health related, the officers don't have to complete anything else. Other than that, if they put their cursor over any of those blue words, a help field will show up and they'll be able to determine if it's appropriate to check that box or not. A check means yes, a no check of course means no. And then there is one little field at the end that there is a free form that they can type any kind of comments into the next tab in case there's something they don't want to put in the original report, but they want us to be notified of something. Some of the things that we're really looking for, and the first one is loss or local outreach of suicide survivors. It's part of our clinicians at SHI, but also volunteers of people who have lost loved ones due to suicide. They volunteer to assist in preventing other people who have lost people to suicide from succumbing to it as well. It's a national model. I believe it was started in Denton Police Department here in Texas. And in fact, 2 of our people are at a national conference up there right now in Fort Worth getting some additional information. The second thing is jail recovery and post-arrest contacts. We are trying to get with our jail liaison through the Shibe Center to start working with him a little more closely. Right now they have 2 positions, but only one of them is filled, so they're a little backlog right now. First idea is to try and get that person to engage or re-engage if they had it before mental health services and reduce any future criminal arrests. And the secondary objective is to reduce tensions and hostilities that those individuals may have towards law enforcement. And hopefully that'll be, in the next few months, we'll get that ramped up. And that's what I have for me, so I'm going to turn this over to Michael.
All right. Hi, I'm Michael Yarbrough, Sergeant with Eldorado County Sheriff's Office. I'm in California, just east of Sacramento, if you're familiar with that area. Just to give you some of our demographics, roughly 183,000 people in Eldorado County, encompasses about 1,786 square miles. There's 2 incorporated cities within our county. In those cities, the combined population is about 30,000, so the Sheriff's Office were responsible for over 150,000 residents. Our staff is about 250 sworn, which includes our correctional staff. There's 2 offices. The main office is in the West County in Placerville, and there's a substation up in South Lake Tahoe, and that's where I'm currently stationed. We're recipients of the Justice and Mental Health Collaboration Program grant, is 2013-14. What the grant did was help us get a majority of our officers trained. We have several officers been through a 32-hour class. It helped our field operations. The officers will conduct field follow-ups on overtime visits, not during patrol times, because they don't want to be listening to the radio. They want to make it very personal and specific for that contact with the follow-up. I'll talk more about follow-up in just a moment. It also helped with our administrative work, time reviewing reports, setting up meetings, and attending meetings. There's currently 3 sergeants and roughly 14 deputies that are assigned to this. It's all collateral assignments. We don't have anybody assigned to it full-time at this point. So the field follow-up visits are conducted with our deputies. Some of the visits, what they'll do is they'll check on the consumer. They'll go out there, see if there's any needs, what they need to be successful in the community. I have a quick example of a gentleman that was incarcerated for stabbing his brother. Once he was through the court process, he was diverted over to a mental health court. Before he was released, my partner and I visited with him, let him know what resources are out there, and offered our services to follow up with him to help make sure he's successful. And we did. We saw him a couple weeks later. Good thing, because his house was fine. We talked to his family. Everything seemed to be going fine. We did check his medications. He only had like 3 days of medications left. He didn't have any way to fulfill it, didn't have a doctor's appointment or anything like that. So when we talk about MDTs in just a moment, you have these collaborations. So we called mental health. They got him an appointment immediately the next day. So the psychologist can see him, write a prescription. He wasn't able to pay for medications, which, again, I'll talk about in just a moment, about emergency funds. We have a small amount of emergency funds for medications, which is able to pay for the medications. We got this young man on track. He's been doing great since, reemployed, and back on track. He's doing well. It just took some time for his being out of custody for his Medi-Cal, Medicare to kick in so he can pay for his own medications. Some of my duties are, we prioritize 5150 reports, which in the state of California, 5150 penal code is what we use for our mental health detention, our 72-hour detention. Not all reports that come through when somebody's detained, they don't require a physical follow-up. And some of the examples that wouldn't get a physical follow-up would be people that live in group homes or care facilities, because they're already receiving services. So we wouldn't be leaving a resource package, which I'll talk about in a moment. Other people will be homeless consumers. If we don't have anywhere to follow up on them, we're trying to offset that by, if there's a detention, we'll leave a package with their property, and hopefully they can look at that information as well. Talk about people who have no previous 5150 cases or calls for service, or what would be considered minor. I just don't want to live anymore because my girlfriend broke up with me, those type of things. We'll mail resource package to them, to the home. We're trying to link to services, and you'll see what I'm talking about when I show the resource information here. As far as our program, we're really trying to push, talking to mental health and National Alliance on Mental Illness is linkage to resources, letting everybody know what's out there, and just over and over and over. So if they get services, the information mailed to them several times, that's okay. It's just you keep pressing it, because it's going to take, it may take several times, up to 5 or 6 detentions before somebody actually starts getting the help they need. We operate under our case management model, which is, again, through mental health. It's basically a wraparound service. They don't look at the consumer that having one issue. They look and see what are the overall problems, and then as a collaborative, they work and see what we can do to address all the problems to help them succeed. For our tracking of case numbers, once the incident's written, when it's assigned to a deputy for follow-up, whatever follow-up they do with that consumer is followed up on that with a supplemental on that case number. That way it's tracked, and we can see what type of recommendations were made. The deputies have authority, and they've been trained and experienced enough when they go out and do visits to see if we need to give further services, what else they might need. If there's anything they're lacking, we have resources to contact and try to take care of it right then, or they can simply close it out. The consumer's doing great, maintaining the mental health program or their plan, no longer needed for our services, so we could document that, and they can let us know to close it. So the resource package I referred to, it encompasses a mental health historical form. That's a historical form which we encourage the families to fill out. It has a lot of information about the consumer's history. That could be helpful. In the state of California, you can use that information, and you can use historical information to assist in making a detention. It also, if they self-admit, they go to a hospital on their own for an emergency, they can hand that form to the staff there, and it helps guide them as well. We give out information form, which I'll show you in just a moment. I have some of these forms attached to linkage to services, and just kind of help guide folks through the process. Any NAMI information, family-to-family classes, peer-to-peer, anything that they have current, we'll put current information in there. Those are great resources. If you're not linked up with NAMI, you really should be. And a mental health emergency 911 guide. We were able to talk to San Mateo County, had this guide originally, and they allowed us to make it our own and get it out there. It's a really good guide. It helps families walk through, but I'll have that example as well. Okay, if you can read it, this is a general letter that goes out. It's a crisis follow-up resources. So it gently says that we received, without being specific, received a mental health call at your residence. Lets them know that deputies are trained and available to deal with situations like this. Talks about a little bit of historical information, tells them to fill that out and what they can use it for. And again, the linkage of services below, the important numbers for county mental health, NAMI, Veterans Affairs. Just to start with, somebody can get answers for if they have other needs. I think most of these numbers can help direct them to proper needs. This is the outside of it's a trifold flyer, a 911 guide. So it tells you generally what's going to be inside. Linkage to numbers on the back. The middle will tell you what's going to be inside, and then front 911. This is the inside of the flyer. So this helps walk family members through every time. And if you want to have a better contact, because again, these consumers may be repeat, so you want to have a positive contact with law enforcement and productive. So this helps walk the family member through what to be prepared for, what to say to dispatchers, keywords, requesting a CIT trained officer if available, tells them not to hang up, etc., stuff like that. It also lets them know what to expect if their loved one's detained. And information, like I'm talking about with the 911 flyers, and much more information are given out at kiosks throughout the county. These are a couple of our local NAMI folks. They're really nice, real helpful. I think we have 7 kiosks placed throughout the county that have supporting information and resource information. I think our success, which I'll show you at the end, how we're doing, this is how we got here, is I think our success is working through a multidisciplinary team, the MDT. It's a collaborative you create. It has most of these folks on the left. You want to have people involved that are stakeholders, anybody that might have positive input for your to deal with the consumer's needs. So obviously the mental health and hospitals, law enforcement agencies, NAMI, other things like public guardian, adult protective services, public defender. These are monthly. We have a MDT meeting, and most of these folks are here so we can talk about a consumer and see what we can do to get this person on, because the people we talk about at MDT meetings are people that are in more need of what's going on. And that's how we address. I'll talk about the MDT in just a moment. So this collaborative brings together various organizations, like I said. It works with organizations. I have a typo on that one. Not organizations over the county, over county mental health, but over the topic of it. Anybody that has something to do with mental health or related topics would be in this working group. It helps the flow of services. Having this personal contact, it's easier to call up somebody, hey, I have a specific question, instead of calling an agency, explaining stuff. And when you see these people in the same room, the collaborative can get answers a lot quicker. So the MDT helps problem solve and clarify legal standing issues. An issue that came up, which was large for us, and from what I hear, it happens quite a bit, is mental health providers who fall under HIPAA are able to talk freely without violating HIPAA with non-medical providers, which is most of the people in the MDT group. The providers are your mental health and your hospitals. So we talked about this at the meetings, and most hospitals, if not all, and mental health care providers will have release forms. So if a family member is brought in for a detention, they're not able to give other family members that information without a release form. So our county mental health, they already have an existing form. So we just talked to them during this meeting, saying, what if our deputies had this form, and if we did a field follow-up, and this is a person that needed to be somebody discussed at the MDT, we ask them to fill that out now. And most of the people are being cooperative, and they give us a release of information, which we give back to mental health. So they provide, or they maintain the release of information, and they're able to talk freely about this consumer during the MDT group. The non-medical providers were able to give information freely, but we don't fall under HIPAA as such. Discussed a little bit about the emergency funds. We have a nonprofit organization that maintains roughly about $2,000 through grants or donations, and it is just emergency funds. It's something to have, because if a consumer gets out of jail, they're going to have roughly 2 weeks worth of medication, and if they're not able to get the funds to buy their medication, we have a way to help them stay current on medications. Our group also talks about the flyers, historical forms, and training classes. Like I showed you a lot of the flyers, we just didn't create that ourselves. That's something we took time. We talked to stakeholders. We want to make the wording proper and respectful, so it takes a little time. And we network to problem solve on a daily basis. This is where your personal contacts come in to help you out. We had a gentleman that was having numerous batteries within the family, and we go out to give services. He presents well. This is after the fact for batteries. You talk to the family members, and they'll tell you a little bit of history. But he presents well to the deputies, so they can't articulate a detention. He lives at home. He's not gravely disabled. His room is horrible, just disgusting, but not something we could articulate. So we call over mental health and say, hey, I have this problem with this guy. I think there's something there. Can we have a clinician come out? And so you set up these meetings, and they generally didn't come out for regular field visits. But if you have this personal contact, of course, you can coordinate something. They came out, and after a short interview, the clinician was able to articulate a detention. But now this gentleman's medication compliant for most of the time, and we know of him when he's not compliant. We know how to get him his services as quick as we can. So how it all pays off, what we started looking at in our year of 2013 and 14, the years were really close on our calls for service. Our case numbers of just over 540, right around there. In 2015, we had a pretty good decline down to 502. Looking at our 2016 numbers for the first half of the year, roughly, you can project out 196 cases, averaging 32 a month. In summertime, I'm sure that spiked up a little bit, but it's going to show a pretty good decline still. And it's not just the Sheriff's Office numbers which are declining. We're looking at South Lake Tahoe, their office, their crisis assessments have declined since from 2014 to 15. And what I look at in countywide is an important number, and this is from mental health as well, is their known repeat consumers, the people they're dealing with constantly, in 2014 was an annual 23% of ER visits, having episodes. In 2015, that was down to 10%. I attribute that to the success of the MDT, everybody working together to work on resources and helping this individual get what they need. And of course, law enforcement-wise, we always like to know that the use of force countywide is down. The officers with the training, I think it gives them a little extra insight, has them slow down and recognize what type of person they're dealing with, which will reflect the use of force is down. We get several positive reports from NAMI, or they go to every one of our mental health meetings, and that's what I like to hear, because they're getting feedback from our family members out in the community. And I think that's my presentation, my email and work phone number on there. Thank you.
Thank you, Michael and Sam. We have a bunch of questions that have been coming in, and Talia Peckerman will be reading some of those questions off and directing them to the relevant presenters.
Okay. So the first one, we'll start, this one either of you, Sam or Michael, you could both answer it. Let's just start with Sam. Do your local law enforcement officers have a database of individuals identified to have mental health or substance abuse history? Or I guess then follow up, how would you identify who does? Sam, can we start with you?
Yeah, we don't have a specific database yet. We are talking about making a database of consumers and individuals. What we usually do to get our caseload is we will get, I go through every report every day that I come in and go back from when I last looked. So I look at every mental health related report, every emergency detention that a patrol officer did, or any call that had a mental health aspect, and start looking at it. One of our persons that is in the unit has been in the unit for almost 4 years, so he's pretty familiar with most of the people that we deal with. And then we just go from there to see if it's someone who repeated or someone who's just came in.
Okay, great. Sam, thanks. And do you plan on sharing that database with other stakeholders or agencies, or communicating the data within to them?
It hasn't been discussed yet, so I don't know how far we're going to go with it yet.
Okay, great. Thank you. And Michael, same question. Do you guys have a database to identify people with mental health or substance abuse history?
All we have is we can flag a person or a location to note anything in our notes. So if they contact an individual, dispatch will get, if they've been noted to have a mental health history, and these are triggers or points to touch on and not touch on, that'll flag in dispatch, and they'll advise us over the air that there's information that we need to be aware of, and it can be for the person or the residents.
Okay, thank you, Michael. And the next question goes to Michael's program. Did the deputies involved in your program, did they volunteer or were they assigned?
In our program, it's mainly volunteer. It's a specific, not everybody fits. It takes a certain type of person, I believe, and the sergeants, we talk about the individuals as well. So if somebody applies or wants to be part of the program, that's somebody we talk about, not just everybody's accepted, because it does take a passionate and caring person, so they volunteer.
Right.
Let me just follow up on that question as well. The Madison Police Department as well has a mental health officer program, and in that situation they have both volunteers and officers who are assigned mental health officers. The volunteer pool at the moment, I believe, is approximately 20 officers, and they also have 5 full-time mental health officers, and that's their workload on a daily basis.
Thanks, Nikki, and thank you, Michael. And so this question again goes to both of you. This time we'll start with Michael first. Someone asks, I was wondering what the panelists believe the impact has been on practice of recent highlighted cases of the use of police lethal force involving individuals with mental health problems. Michael, can you speak to anything regarding that?
No, so in case specific, every person and every diagnosis very specific in how they react to law enforcement. It would be really hard to generalize. I would just say overall with the use
I think the question's asking, do you think that the recent highlights of the use of force by police involving individuals' mental illness, has that had any impact on the practice protocols and what you guys are doing there?
Oh, I apologize. Yes, I think it has.
Oh, that's fine.
It's mandated in the state of California now that every officer receives CIT training. So that would be a good effect.
Okay, thank you. And Sam, how about you?
Well, the same thing. We have various levels of mental health training, CIT training, 8, 16, and 40 hours. The minimum is 8 hours that each officer has to go through, and those of us on the team are 40. I can't say specifically how much the other cases have affected it. It's kind of a little above my pay grade as far as like command staff if you're talking about policies, but I know with our department we do probably have a fairly low use of force when it comes to that, especially with our unit. The number one thing we use is verbal communication. Out of the, well, I've been in this position for right about 3 months, and I've never had to actually use force, but I've had to use restraints on only 2 or 3 individuals out of all the ones that I've come across in the last 3 months.
Okay. Thank you, Sam. And Sam, the next question is for you as well. How many officers or deputies in total do agencies who have dedicated mental health officers have? Do you know that, or is there anything you can say to speak to that in terms of the ratio? You can talk about your department as well. I'm
sorry, the question is the ratio of our mental health officers to the regular officers?
Officers/deputies, exactly.
Okay. Well, we have about 106 officers, and we have 3 dedicated full-time mental health officers. We don't have any volunteers specifically like the other agencies do with the CIT type volunteers right now. And for the longest time, we've only had 1. I got transferred in July, and we just had our 3rd transfer at the beginning of this month. It is something that our department is seriously pushing. All of us would like to see it even grow more than the 3 that we have. There's still plenty of work for them to do and plenty of other outreach that we've anticipated to look in the future, just haven't had the opportunity and manpower to do it. So now that we have 3, we'd see how far this takes us and see if we can get some more positions at a future date too.
Okay. Thanks, Sam. And Sam, do you have any examples of encounters with someone with mental illness who has lack of insight, and how do you handle that?
Lack of insight as far as, I'm sorry?
Into their mental illness. They're not aware that they have one.
Yeah, and that makes it, right, that makes it difficult, because if they don't recognize, don't realize it, don't want to admit to it, it's very difficult to get them treatment, because as law enforcement, if we determine that it is an emergency situation, a crisis, and we need to get them screened, our emergency detentions are good for 48 hours, not including any weekends or holidays. But all that means is that they get screened by a mental health professional. It doesn't mean that I can force any kind of medicine on them, treatment, peer-to-peer, or any of that. So it makes it difficult when the person doesn't have the buy-in, and that's one of the things we try and do by those home visits and repeated visits and jail visits, is to see if we can get that person to accept the fact that they're a person who has an illness that needs to be treated so they can be a more productive member of society. I've had several success instances, and I've had some that are just absolutely resistant, even with the facts in front of them. They just don't want to see it.
Okay, thanks, Sam. And Michael, can you say anything to that? The lack of insight, encountering people with mental illness who have lack of insight.
I think Sam's correct. You run across people in all aspects, and he was saying that some people accept it, some don't. Some aren't gonna, but that's where the mental health professionals, we can get them there, and we can articulate what we observe as being a symptom or being problems, and hopefully the mental health professional can work on that. Yeah, you run across all types.
Okay, thanks. Next question is for Sam. Who and how is it determined whether a mental health officer or family member will transport the subject of an emergency detention to a facility?
We have 2 ways that people get screened if they show up at our hospital. If we as a mental health unit find them, we usually do 100% of the transportation. If they end up at a hospital, the local hospital on their own, it would depend upon if they have insurance or not. The hospital, if they do not have insurance, they get screened by SHIB, and if they do have insurance, they get screened by a private organization called NICS, which is a mental health out of San Antonio. Majority of them, the people that get screened by NICS, usually go by ambulance, and the majority of ones that get screened by SHIB, usually we take care of. Most of that's insurance and paying for it. Usually, it's pretty rare that a family member will transport, except in the case of juveniles. That's usually where about 50-50, where we'll get either the family or law enforcement to transport.
Mm-hmm. Okay, and follow up to that, when a non-mental health officer, I guess an officer from another unit, transports the individual, who pays for that overtime?
The department takes up the bill. We pay for all the overtime.
Okay, thank you. Okay, the next question is for Michael. Michael, what would you suggest that a therapist who is now dedicated via mental health law enforcement grant to law enforcement do to encourage more calls from the patrol officers? Essentially, how can I get them to resource my services more frequently? Do you have any advice?
We have our starting point is county mental health, and they go out from there, because our county mental health only deals with severely mentally ill, and if somebody's diagnosed to be like mild or moderate, then they would be directed from county mental health. And if that's a care provider in the area, so they would contact your county and make that rapport there, and let them know what services that they can offer as being a mild or moderate, or even if they're severe. I would have them contact the people who are going to deal that out. Will be county mental health in our area.
Okay.
Another point we're seeing coming from the grantees that we've been working with, and this is a question that we get asked quite a bit. One thing that's important is that we try to build awareness within the department to make officers aware of your position and your current position and role in the department. So awareness building is a big part of it. What we've encouraged teams to do is to, one, go to the roll call sessions and let the officers get familiar with who you are and what your role is. Also, try as much as possible to do ride-alongs. Again, it's important to build that rapport between the officer and the mental health personnel or behavioral health personnel. And another suggestion that we've seen and we've given to grantees as well is to ensure or try to have what they call small information cards. And those small cards are almost like pocket cards that the officers can be given with the information for the mental health personnel.
Okay, great. Thank you. Thank you, Nikki. Okay, the next question I'm going to ask actually both of you to answer. Let's start with Sam. How did your specialty unit come about? Who are the types of stakeholders needed to be brought to the table to get this type of unit organized? So back to the basics.
All right. Our unit was started with a one-officer unit back about 8 or 9 years ago. Our department saw a need for a mental health officer dedicated, so they started with the one officer. Our calls, and this is more, I guess, more anecdotally, because I've been with the department for almost 24 years now. Dealing with someone in a crisis back in the day was like once a month, kind of like a, hey, cool, somebody's in crisis, and then it went to like once a week, and now twice a week, and now 3 and 4 times a day we're dealing with individuals that have gone into crisis. And so with the one officer, they decided they needed a lot more, so they applied for the grant, and now we have the 3. Some of the stakeholders you need to look at, I'm not sure how each state is organized, but here we have a mental health authority for the county, so I would go with them. You definitely want to talk to any of your local hospitals or any of the clinics that you have, medical and mental health clinics. See if there's already any outreaches, such as the NAMI family organization, or if there's any other peer-to-peer groups. Veterans groups are a great also way to start.
Okay, great, thank you. And Michael,
yes,
do you want me to repeat that question?
No, I understood. I was listening to Sam. He's got a good eye on it, and it does start. We had ours almost 10 years ago, and we started with our basics with the people who have the most stake involved as well, the mental health, the hospitals, law enforcement, NAMI, and we expanded down to who else can help, public guardian, drug and alcohol, APS, or adult protective services, public defender, just anybody that can be helpful within this process. But we did start off with just some of the key, I think we had a MOU several years ago just to get it started.
Okay, thank you. We have a couple of questions here regarding HIPAA and the database, HIPAA laws and other information sharing privacy laws. Michael, can you speak to any of that? How you, I don't want to say, quote, get around those laws, or what you do with that?
No, I could speak to that, and yeah, I might have said get around, but I think just it's within the law. Because we need to work as a collaborative, and we respect our mental health or medical providers, what information they can and cannot do. So when we come up to that bump in the road, the way we can get information and share evenly is if that person gives a release of information. And the hospital, both our hospitals and our county mental health have those forms exist. And they've been through county council and all that and tested, and so we didn't have to recreate the wheel. We just didn't know what resource we had available at that time until we really talked about it, and then we're able to get that out. And if a consumer gives us the release of information, we give it back to county mental health because they're the ones that are really under the HIPAA thumb, so they can talk about that consumer. We may be at meetings where we've had a release of information filled out, and we'll bring up this person's name, and the provider, they know if the person's taken back their waiver, which they can do, and we're okay with that. They'll just say, well, we can't talk about that person, or I can't talk about that. So we know, okay, well, they've withdrawn their release of information, which is fine. But generally, that seems to be going pretty well, and they're legally able to talk about the consumer.
Okay. Great. And follow-up to that is, have you had any contact with the ACLU, American Civil Liberties Union? Have they ever gotten involved in any case or anything like that?
Not at Eldorado that I'm aware of.
Not in San Marcos either.
Okay. And Sam, do you have anything you want to add or talk about in terms of HIPAA and information sharing?
We have actually talked about looking into that waiver release that Michael had spoken about. Pretty much right now, the hospital, through some education from my predecessors, have when a consumer is in crisis and they're calling us to put attention on somebody, they've come to understand that we're able to see that information so that we can make a informed decision. That doesn't mean that, of course, 2 weeks later when they get released in the hospital, we can go see it. But during that initial crisis, we've done pretty well with our local hospital. We're also trying to train our officers in what they're allowed to ask and what they're not allowed to ask as well.
Okay, great. Thank you, guys. And I'll just stick in there that it's always important to remember that HIPAA and the other information sharing laws were put into place in order to expand and improve access to health care. So just always something for us to remember. So thank you for those questions. Okay, next question. Let's start with Sam for this one. How difficult has it been to secure mental health service providers to work in collaboration with your department?
Since we work pretty closely with our local mental health authority, they're there, and we work with the MCOT team. They have 4 people plus the extra people that they use that are part of their other services. So we've been able to have that. One of the biggest issues we're having with our local hospital is that they're trying to start, and they've been in talks for a while now with another company to get another inpatient mental health facility. The problem is finding psychiatrists, from what they're telling us, is extremely difficult, and I know that we have a good shortage of that kind of providers in this area.
Okay, thank you for that. Someone says here, my county is in the infant stage of mental health assistance and law enforcement. How long did it take you to get your programs up and running? Let's start with you, Michael.
You know, it's always evolving. I think, you know, initially you have to get the training out to officers, and however long it's going to take you to have somebody come in and train your department, it could be several months. The management of the program isn't too difficult to do. You know, I would just guess maybe up to 6 months given training time, and then you also have to set up collaborations meetings, like your MDT meeting. You got to find people who are involved, make those personal connections, and those monthly meetings. So it could take up to roughly, I would guess, 6 months.
And how about for you, Sam? How long did it take you guys to get it up and running?
I wasn't really involved in the initial stages, so I can't really say, like back in the day, 8 or 9 years ago.
Right.
But it does take a while. You've got to get all those stakeholders. If they're not buying in, you've got to convince them to buy in. So I would say 6 months would be like a minimum. I mean, if you can get something going within even a year or two, I think you're on a good track. But it's not something I think that I feel is going to go very quickly, because you've got so many other entities, agencies, and organizations that you've got to deal with. Because just a law enforcement agency alone, I mean, I wouldn't even say you're going to tread water by doing it by yourself, because you've got to have that support.
Okay.
And just to follow up on that, thank you for mentioning collaboration. Again, something that we're seeing is that the importance of collaboration and the importance of having those initial meetings. It makes no sense sometimes to reinvent the wheel, so a good place to start also is identifying jurisdictions or agencies that have a program similar to the one that you're hoping to implement. Try and reach out to those programs to see what is taking place and what has been put in place. Leadership buy-in is also very important, so we encourage agencies that are thinking about either starting a program or enhancing a program to have conversations with top leadership in both law enforcement and behavioral health agencies, or whichever other key stakeholders that you'll be partnering with, because that's very important to get leadership buy-in and get stakeholders engaged. I will also say that there's no magic number of length of time that it will take to start or get a program going. If you talk to a department like Houston, for instance, they'll tell you that it's been 20 years in the making. For other departments, it might be a shorter time period based on a particular grant, for instance, the Justice and Mental Health Collaboration Grant. So my advice to you would be patient, take your time and do the front work very thoroughly so that the program is sustained once it gets up and running.
Thank you, guys. And just curious, someone asks here, and either of you can answer this or both of you can answer, do any of your officers receive any web-based training on this topic, or is it only in-person training on the topic of mental health and de-escalation, that is?
For us, it's in-person shift training or more formal, actually, 8 to 16 or 40-hour classes.
The same for California. There are classes you go to. We have 32-hour classes. We put on at least 10 with our grant money. We put on 10 classes for local agencies. We also had a 4-hour class for non-law enforcement agencies for awareness and help community buy-in as well. It really opened up quite a few people's eyes to what's going on in our area. No online stuff.
Okay, thank you, guys. And we got a question here. How do you treat individuals with brain injury differently? And what type of education or training do you all receive surrounding brain injury or TBI, traumatic brain injury, since it can be invisible and is not always apparent? Sam, you wanna give that a go?
Yeah, and I'm sorry if there's noise in the background. They're doing construction here. So that's why one of those, talking to family members, medical providers, is important if you can, to try and get the backstory for some of these. Under, of course, Texas law is emergency detention, you have to have a mental illness, and if everything is based on a TBI, we can work on getting them resources, but we cannot involuntarily put them in to get any kind of resources. The difficult time is when you deal with people with TBIs that have underlying mental health issues, and determining which one you're going to have to deal with sometimes is sticky, and whether it's TBI or anything else. Alzheimer's is a big one. We have an Alzheimer's unit, a private run here in San Marcos, so all those kind of medical issues that coincide that may or may not have a mental health aspect are very difficult. So that's why getting as much information as you can is paramount.
Okay, thank you. And Michael, how about you guys? What do you guys do surrounding TBI?
That's a good point, and I was actually almost typing back to that lady brought that question. It's a good question. It's a sad thing because TBI, you only have 2 years post-injury. They're going to be where they're at. So depending on that, like I've contacted the VA because I figured they'd be a better resource. Our county mental health does not deal with TBI, so I'm trying to look for other resources and other specialties out there. The VA will refer out to speech therapists to help regain some brain cognition, but that's about it. So if you have people post 2 years, you just have to know that that's how that person is within your community, and there's really, out in our way, there's really no services. There's private services in Sacramento, but nothing locally.
Thank you both. I'm going to add in there that a TBI, a traumatic brain injury, depending on where the brain injury is, oftentimes a lot of the symptoms and behaviors will resemble that of a mental illness. And as mental health officers and other responders are not out there to diagnose, they may not know whether it's a TBI, mental illness, mental health crisis, a first break, or anything like that. That's not their job to necessarily figure out. It's job to de-escalate the situation and figure out where can I bring this person that is appropriate and is going to get this person help. So I'm just going to throw that out there. Next question. Let's start with Sam. Sam, how would you respond to folks who say that responding to calls that mental health calls for service is not a legitimate police function?
Well, I'd have to disagree. I mentioned earlier about how much our calls for crisis situations have expanded over the years. I don't have an exact percentage to tell you how many of our calls are mental health related, but I can tell you it's a sizable majority that take up our time. Some of them are individuals who refuse to get the treatment, so they're constantly getting in contact with law enforcement and other people for typically your minor offenses, such as like criminal trespassing or something along those lines. If the mental health issue is not going to go away, and we treat all individuals as people who just happen to have an illness, so no matter who you are, we're going to treat you fairly as best we can. But to completely ignore the mental health community is like trying to ignore the elephant in the room.
Okay, thank you. And you, Michael, how would you respond to folks who say that responding to mental health calls for service is not a legitimate police function?
Yeah, I think Sam's right on that as well. It's community care. As law enforcement, we just don't go out and write the ticket for the law. It's care for the whole community. If a person's in crisis, they need help. They're medical, maybe in a medical crisis, but something that we're going to contact first. We're going to help them get the proper resources, and you just would be almost criminal by not helping people out, because that's what you get in the business for.
Okay, great. We're just going to do a couple more. Thank you both for that. Is there anything being done at your local jails to address incarcerated mentally ill? I think that this also speaks to a little bit about what Nikki was talking about in terms of collaboration and everyone getting on the same page and looking at this from kind of a systems perspective. So, Michael, is there anything being done in your local jails to address incarcerated mentally ill?
Yes, we sent several of our supervisors and several correctional officers as well that work in the jails do the full CIT training so they can recognize individuals that come in or their day-to-day maintaining the folks over there. We have a contract through, for mental health services. We contract out. They come in so many hours, or they do TV interviews, basically. So there is that, and it is helpful. We get called all the time from the jail saying, hey, come in and talk to this person. There's something going on, but we don't know. Or you're going to want to talk to this person before they're getting out in a few days, so we can meet them before. Like we had the young gentleman that stabbed his brother. You build this rapport before. So our jails are pretty darn educated in that, and they're happy to have that education, I believe.
Okay, thank you very much.
One other question that came up is, do you find that many of the mental health individuals that you come across are also struggling with drugs or alcohol addiction? Are these individuals handled differently, or are you familiar with drug court? So let's start with the first part of that question. Do you find that many of the mental health individuals that you have come across are struggling with drug or alcohol addiction, and are these individuals handled differently?
Well, I would say for us, definitely yes. There's a large percentage who will self-medicate with alcohol or drugs. Around here, methamphetamine is a big one, along with marijuana. They're not necessarily handled differently, except for we need to figure out, is this a mental illness crisis they're having, or is this a drug-induced psychosis they're having? And unfortunately, sometimes until they either go to the hospital or until they get arrested and are there for a while to sober up, can we actually give them services. As an example, we have one individual that we've tried to do outreach with several times, and he was very resistant to it, but he was also a pretty heavy meth user. He got arrested about 2 weeks ago for assaulting one of our officers, and so now 2 weeks sober, he's still exhibiting the psychosis, so now we know it's not just meth, and we can try and get him the assistance. But yes, it's pretty prevalent in our area at least.
Okay. Thank you, Sam. How about you, Michael?
Yeah, I can speak to that. I speak with our supervisors over at mental health, and they tell me the averages go from 70 to 80% of their consumers are dual diagnosis or self-medicating, I mean. So it's quite high, and Sam's on point as far as you just don't know at times. Sometimes you still treat it safely and respectfully and do what you can at the time.
Thank you, Michael. Okay. And a question regarding the homeless population. Michael, can you share any successful approaches regarding dealing with the homeless population in your area? Hello? Michael? Okay, Sam?
Yeah, we don't
you might have lost Michael.
Okay. I don't have a specific outreach at this time to the homeless. However, we do have several of the clients of our Shibe Center have been homeless or are homeless time to time. And unfortunately, that whole previous question involving the substance abuse really plays into a lot of that. When we can get them on, real decent medication and can get them stable and off of the recreational illicit drugs, they tend to do a whole lot better. And keeping them with the housing, keeping them with their services, keeping them with their psychiatrist appointments, everything else is something we strive for, but I don't have a specific outreach at this time for like homeless.
Okay.
And just to follow up on that question as well, quite a number of law enforcement agencies have been starting or are enhancing their homeless outreach teams. A good program that we see is coming out of Houston Police Department. And Houston is one of our law enforcement mental health learning sites. So if you go to the Council of State Governments Justice Center website and type in law enforcement mental health learning sites, you will see some 6 agencies that have exemplary programs. And among those 6 is Houston Police Department, and they have a homeless outreach team that has been doing great things, have gotten amazing results, and they're responding to an increasing number of individuals who are homeless on a daily basis. But if you should check the websites, for instance, for homeless outreach programs, you'll find quite a number of programs that are in place at this time.
Thank you, Nikki. Michael, just curious, do we have you back? Okay. All right, thank you, Nikki, and thank you, Sam. The next question is, do officers receive any kind of mental health training at your respective police academies, or is all the mental health education through the CIT program? I'll just first mention here, so we at CSG Justice Center, we recently surveyed the states and territories to find out state standards for mental health and de-escalation training. And so I'll note that a lot of about 95% of states who responded to the survey do have some sort of state standard around including mental health and or de-escalation training in their basic training curriculum. So then that would be at the academies. But I'm also going to go ahead and let Sam, Sam, do you want to talk about what goes on in Texas or by you guys?
Yeah, I don't know what the minimum is for the basic police academy. It's either 8 or 16 hours. The way we do our training here at our police department, we don't have an actual full police academy here, but once the cadets finish their police academy training, we have a 1 to 2 month, what we call a mini academy, where we go over things we want them to know. Right now in our mini academy, we have 8 hours worth of mental health training in addition to what they just got at the academy. And we've been discussing that amongst ourselves to increase it to 12 or even 16 additional hours on top of what they got at the academy. And again, we're trying quarterly to at least get 30 minutes to up to 2 hour training for various things quarterly with all the patrol officers, as well as what we're working on.
Thank you, Sam. Okay. And another question is, someone asked here about what is the breakdown by race and age of mentally ill people who have encounters with law enforcement? So I'm not going to directly answer that question, but I am going to direct you to a website. If you just Google Washington Post database, this website, this is a database that was started in 2015, and they have the breakdown of use of fatal force by state, gender, race, age, mental illness, if there is a weapon, body camera, and some other factors. So you can really get the bulk of that information there. All right. I think that might be, sorry, Olivia is going to send that link out right now as well.
There was another question regarding the Justice and Mental Health Collaboration Grant and whether or not the grant supports the positions that were mentioned. So first I'm going to direct you to the Bureau of Justice Assistance website, where you can find information on the Justice and Mental Health Collaboration Program Grant. And if you're writing, that's www.bja.gov, and in the search box you type in Justice and Mental Health Collaboration Program Grant. Just to give you a little information on that, it supports innovative cross-system collaboration for individuals with mental illness or co-occurring mental health and substance abuse disorders who come in contact with the justice system. And as the term suggests, Justice and Mental Health Collaboration Program, this must be a partnership between law enforcement and a behavioral health/mental health entity. Typically, the grant notice goes out in February, and it closes at the end of March to mid-April, and the awards are made the end of September to the beginning of October. So there's a new cohort of JMHCP grantees who will be provided with awards in the next few weeks. The awards are used under different categories. There are 3 categories. The first category is a collaborative county approach to reduce the prevalence of individuals with mental disorders in jail. Category 2 is a planning and implementation grant, and that's for programs that are hoping to start some type of initiative, police mental health collaboration initiative. And category 3 is an expansion grant, and the expansion grants are for programs that are already in place, and you're looking to enhance that program in some way by adding a new element to that program. And the question had asked if the funds were used to support staff. It has been used in some agencies to support staff. And another innovation that I want to mention to the group as we're here is we have recently developed a police and mental health collaboration toolkit. And that toolkit will be hosted on the Bureau of Justice Assistance website. And it's basically a compendium of resources for agencies, for other entities that are interested in developing or enhancing some type of police mental health collaboration program. So on that website, which is expected to be launched October 15th at the IACP conference, when you go to that website, you're going to find a host of resources, including video clips, including PSAs, including policies and procedure documents, interviews from experts in the field. We have research articles and a host of other types of resources. So that's something to look out for. It's the Police Mental Health Collaboration Toolkit, and that will be launched mid-October and should be online shortly. There are no other questions at this time, so I would like to say thank you to the presenters, Sergeant Michael Yarbrough and Corporal Sam Myers, for your time. Thank you all for joining this webinar, and we look forward to hearing from you. As Olivia had mentioned in the beginning, the webinar as well as the recording will be posted shortly, and you will get notification when that happens. Have a good day, everyone.